Hello, everybody. I'm Daniel Engelman, cardiac surgeon from Springfield, Massachusetts, and president of the ERAS Cardiac Society. And this episode of the Cardiac Recovery Room, we're going to be discussing patient blood management, controversies in transfusion, anemia, when do we give blood, when should we not give blood, and how do we prevent patients from requiring blood. And I'm joined this week by Dr. Ron Salinger and Dr. Sidar Gunyaden. Ron, want to introduce yourself?
I'm Ron Salinger. I'm a cardiac surgeon at University of Maryland and ERAS Cardiac Society board member.
Hello, Serdar Günaydın from Ankara, Turkey. I'm a cardiac surgeon and the board member of the Turkish ERAS Society.
And I'm joined as a co-moderator by Dr. Kevin Lobdell. Kevin, do you want to introduce yourself?
Sure, Kevin Lobdell, Charlotte, North Carolina, and like the others, ERAS board member as treasurer and vice president of development.
Excellent. Let's kick this right off. Does it matter if a patient's given a unit of blood? What are the downsides, and what does the real data tell us? I mean, the sickest patients are requiring transfusions. So how do we determine that it's the transfusion that contributed to complications, both short and long term, versus just the fact that they were so sick, they were bleeding, they were the ones who were anemic?
As you implied, the data on blood transfusions is imperfect, so there's room for disagreement. But the preponderance of data implies that there's both a short-term survival decrease in patients that we transfuse, as well as a long-term increased mortality for patients who get blood transfusions, and that it's not all explained by them being anemic or being a sicker patient population. And there seems to be consistently that finding, and there's some specific papers that have looked at parsing out particularly anemia versus blood transfusion. There was a good one from Mayo Clinic in 24, and there was one from the Virginia Quality Group several years ago. And they both concluded that blood transfusions alone were independent risk factors for both mortality, renal failure, and numerous other complications.
Can I expound on that? Probably being one of the more senior members, we don't talk about this much. A lot of times it's like we just discovered these things, but let's go back in time. Studies done back, 80s and 90s about disease-free interval and cancer surgery and blood transfusions, and they found out that there was something going on, think immunomodulation. But another example of that is when I started at the University of Minnesota, 1986, we used to transfuse patients with multiple mini doses of blood before they got a transplant to make them more immunotolerant. And the point in tying those two things together, above and beyond just oxygen transport and some ethereal benefit, is a real immunomodulation change, right, that changes their long-term outcomes. And I don't think we've powered many of the studies that we look at in cardiac surgery to look at these things.
Sometimes we talk about transfusions as a liquid transplant.
Exactly, yeah.
Which is not a good thing. You don't want a transplant.
Blood is a liquid organ. You're absolutely right. And I think if you look at it at like a 30,000 foot view, people who tend towards a liberal transfusion policy say that, well, blood transfusions benefit patients.
Well, let me cut you off there. So I have a patient post-op day 2, 3, and every time they get out of bed, their heart rate goes up, they feel short of breath, they're exhausted, tired, and their hemoglobin is 7.3. And I'm like, all I have to do is give this guy a unit of blood, we'll push his hemoglobin up, and the next morning we give him the unit of blood and he's running around the halls. It makes me feel like, wow, I really helped him. And this happens a lot.
Yeah, the problem is we don't know that's true. Like, you may anecdotally have seen that happen, but many times, I would say more often, you give that patient a unit of blood and nothing much changes. Now, it's true that some patients do benefit from blood transfusions, but we do not have a good way of telling who those patients are. And hemoglobin alone is a bad predictor of who's going to benefit from a blood transfusion. And the problem is everybody you give a blood transfusion to, you're giving them excess complication risk. So you're guaranteeing them a risk without a definite benefit.
I would agree. And zooming out again, like you say, 30,000 foot level, many of these controversies that we've seen in cardiac surgery have ultimately shown that less is better. In other words, there's inferiority, whether it's track study on transfusion or it's the duration of chest tubes or the number of chest tubes. We always get to less is not inferior to more. And so I think a guiding principle is always to try to get to the least interventions, the least team effect, and just let patients get better on their own. A great example of specifically that scenario you describe would be, we don't do a prospective study on giving that person short of breath and tired on day 6 1 unit of blood. We just know they look better the next day. Maybe they will look better
anyway,
the next day.
Do you think for example, I think all kind of studies like TRICS studies 1, 2, 3, 4, and then other patient lab management studies, I don't believe they made huge impact on a routine cardiac surgeon working in, for example, countries like us. I'm following them.
Like Turkey.
Yeah, like Turkey, Middle East. I've been there, different countries in that area. They read all those studies. In the beginning, they tried something and they gave up. I see a kind of decline in the idealism of the patient lab management in our countries, in Eurasian countries. In the beginning, the interest was very high. Everybody tried something. And now I see a kind of decline because many studies describing many different protocols, many different outcomes. And I think people are now confused. So they want to do something, and so they don't know what to do. So that may be one of the reasons to the change of patient perioperative care from patient lab management to ERAS protocols, because they don't see any new thing to do or any new idea in the patient lab management side.
So let's ask, in Turkey, so you have a post-op patient who's anemic, a hemoglobin between 7 and 8. Do you put them on certain drugs in order to boost their hemoglobin?
Yes. So we can also infuse IV iron in the postoperative period.
Do you give it to everyone or just the anemic?
No, only we have some certain reimbursement protocols. So the patient needs to meet all those criteria to get reimbursed.
Oral iron. Do you ever use oral iron?
We don't use much oral iron, but for example, in OB/GYN, they use routinely for oral iron or in general surgery, but not in cardiac surgery.
Yeah, I just would like to say IV iron is so much better than oral iron, that people should try to get IV iron into all of their inpatient. It's better absorbed. It's been documented to have more reliable results in the literature. And even a single dose of IV iron can have a big impact on post-op hemoglobin concentration. So whenever possible, try to work out a process to get IV iron even into your outpatients.
Yeah, oral iron takes a long time to boost.
Yeah, IV iron has shown results even if it's given 24 to 48 hours before surgery.
I think, Ron, some of the things that you've worked on are maybe the more revolutionary efforts. And when I look at blood management, it's less from the standpoint of transfusing and that sort of thing, but starting with a tank that's closer to full than empty. And then good.
You're talking about preoperatively.
Yep.
So
and good
work on
surgical
preoperative
hemostasis.
the surgeons all say, "Well, I can't do it. I have no time. I'm operating tomorrow. What am I supposed to do?"
If I boiled down patient blood management for cardiac surgery, I would put 3 basic things that basically follow the pillars of patient blood management, but even more simplified. And only one small part of that is expensive or time-consuming work-wise. And so the first part is what Kevin's alluding to, which is treat preoperative anemia. IV iron, and if possible, if you can get it, every anemic patient should get erythropoietin with that IV iron to be more effective. And then 2 is just conserve the patient's blood volume, which is not expensive. You could do it simply with meticulous surgery, limiting hemodilution and how much IV fluid you give. And you can just do retrograde autologous priming, which is not expensive if you're already doing
So both
bypass
of those
surgery.
things require the interdisciplinary actions of other teams. You need your perfusionists on board if they're going to do this
Correct. You need to create a culture of conservation throughout your program.
It takes time. You have to educate and talk and think and pause.
You can just start with the people who want to do it, and then the people who see it happening will eventually come on board.
But let's talk about anesthesia now. It's always the anesthesiologist's fault, so that's easy for us in a surgical milieu to blame the anesthesia.
Yes,
but
that I believe has been proven.
That's definitely proven. But you don't really know what's going behind the curtain, how much fluid they're giving. I mean, you lift your head up and boom, liters have gone in by the time you hit the intensive care.
But you don't, if you create that multidisciplinary approach and that culture of conservation, you don't need to monitor that. I mean, your program can track it, but the anesthesiologists themselves will care about it.
They have to buy in. They have to be part of your initial teams. It has to be their idea. They are taking ownership of that portion. That's the key.
And everybody's got to be watching, right, for these clues. And I'll give you one example that's not just surgical or anesthesia. Reproducibly, one of our surgeons, this goes back probably 10 years, his patients would do well, but they'd come out thrombocytopenic compared to others. I did some reading, some thinking based on this observation, and it appears that the air in the tubing creates a problem with thrombocytopenia. And let's just say this one
causes it.
Yeah. Perfusionist was probably the least concerned about things like that compared to the others.
It's a mechanical problem, sort of.
Correct.
Yeah.
So we got people together, observations, this is how we think we should do it, and the problem went away. And the point ends up being that if everybody's watching what you're expecting and they see deviations, they learn together and they eliminate the problems.
Well, if you put up just a chart of how much fluid each anesthesiologist gave over the last month, there will be outliers, and they will not want to be outliers. They will move themselves to the mean.
Well,
no one wants to be the outlier.
Perfect example of that when we started our blood management focus. Let's say we were closer to average than where we wanted to be, and we got markedly better. Back in those times, 42% or something were getting blood transfusion after coronary. We got to where it was well under 20%. But one of the things that I did was index the number of units of blood when you would look at each surgeon over a year, number of coronaries, and then blood products. Dan, yours was 1.1. Ron, yours was 1.2. Serdar, yours was 0.9. Kevin's was 1.6. Kevin talked about how he was faster and he took people back earlier and everything else. What I ended up doing is say, Kevin, would you join me on a journey of learning and improving this? And guess what? Kevin's got to the mean.
No one wants to be the extreme. So let's talk about transfusion triggers. Every hospital, every system has a transfusion trigger. My first question is, do we need a trigger? Does it have to be some absolute number where at 3 a.m. blood is given to a non-bleeding patient based on that number? That's my first question. Serdar, do you have that in Turkey?
We started by defining some kind of triggers for transfusion, and we just later, stopped doing that because it didn't work very well. As you said, we started the thing for patient-tailored follow-up. Some patients need transfusion at the hemoglobin level of 9, and some doesn't need any transfusion until 6, for example. So we just did all kinds of training for patient management, but now we don't have any specific trigger for
transfusion. You're rare, though. I think almost every program has a trigger. Now let's talk about your trigger, Dr. Salinger in Maryland. You just recently published on this.
Yeah, so in Maryland, we like to call it a threshold because we don't like trigger because our number we use is a hemoglobin of 6. In a non-bleeding patient, we let the hematocrit go down below 18 or the hemoglobin go below 6 before we discuss a transfusion. We don't automatically give one. We often will below 6.
So is that associated with bad outcomes in those patients? Have you looked at
so getting back to Kevin's point about non-inferiority, we did look at our patients and we recently published it in JTCVS Open. We call that, and that's really the third pillar of patient blood management and in cardiac surgery is tolerating the postoperative anemia. So we believe for a non-bleeding patient, I'm not convinced when they need a transfusion, to be honest with you, but I'm convinced that almost no patients with a hemoglobin over 6 who aren't bleeding need a transfusion. And we looked at our data looking at the TRIX3 trigger of 7.5, and less than 1% of our patients got a transfusion at 7.5 or higher. And for our isolated CABG population, just under 11% of patients got transfused at all. And we published this. We just published this data. We didn't publish it to say it's better. We published it to say it's safe, because so many surgeons and other physicians will come to us, and I've had family members of patients who are physicians who think someone should get transfused just because their hemoglobin is 6.5, and we don't do it. And I just wanted something in the literature to show. So we published a few years of our experience doing this and all the outcomes.
So, quick question: you ever had a patient like you're describing? Their hemoglobin's in the high sixes, and you spend all this time optimizing them and getting them out of the hospital, limiting anyone from giving them a transfusion, and they end up at a rehab hospital. On day one of the rehab hospital, they draw the blood and they give them the blood. Oh, he's anemic.
We have had that. We've had several problems. We've had rehabs refuse to take patients because they're anemic, but we've solved that problem partially, by the way, Dr. Lobdell has at his program, by sending over 90% of our patients home. And we get on the phone with the rehabs, which is sometimes effective. We've had patients sent back to the ER for transfusions just because they drew labs. So we haven't convinced the entire world yet that we're right.
I want to expound a moment on this concept of trigger or threshold too, because I think it's vitally important. It goes back to shared consciousness, meaning we all are in this together and we're thinking about it, and then everybody owning it. We decided that these values, like hemoglobin or when you're going to remove chest tube, is a point for a discussion. So the point for the discussion, let's just say for argument's sake, is 7. One of the things that we did was say that's when we will have this discussion, barring something unforeseen.
Which, for the record, I think 7 is a very rational. We use 6, but I think 7 is great.
And again, I'm using that
I like it as a
an
discussion
example.
trigger. It's just at 3 a.m. I'm not sure, as the operative surgeon, I want that discussion at 3 a.m.
Let me tell you how we extended that. You can't be transfused unless the surgeon says we're going to do it, so that we were truly all in it. Because what would happen is, you might imagine, somebody's nervous about it and they want not to be troubled, or they don't know whether another phone call, so then they transfuse the tank is more full. Somebody else is willing to take that risk. But we really wanted to make sure that we were all in this together and we were all learning simultaneously, and that the surgeon is in charge. That's the way we've tried to share that decision-making and consciousness of the whole.
We started out that way. So we've been doing this since 2015, which made it hard, by the way, to get control group for our publication. But we've been doing this for 10 years. And now, for the last 5 years, we don't have to have that discussion.
That's
Yes,
right.
'cause it's
That's an
ingrained,
evolution.
yeah.
Exactly.
But pushing back a little, there is a role for transfusions when you're doing goal-directed therapy to resuscitate patients. For patients who are at risk of AKI, at my hospital, we measure urinary biomarkers, which show us patients at increased risk for AKI 6 to 12 hours after cardiac surgery. And these patients will benefit from more O2 delivery. And I don't have many tools to get more O2 delivery beyond hemoglobin. I can increase the oxygen, increase the cardiac output, but that's it. That's all I have. And I think that balance of transfusing patients who have low output to these stressed kidneys to prevent AKI in some manner may be benefiting these patients.
I think it's been shown that oxygen delivery matters. I'm not sure it's been shown that transfusing someone with low oxygen delivery avoids the AKI.
Well, it gets you back to on pump. Sudar, you're in the operating room and you tell them to have an O2 delivery threshold. Do you use that?
Yes.
280 or so?
Yeah.
So same story. You don't have many tools. So they increase the flow, they increase the pressure, the oxygen's all the way up. Aren't they going to transfuse? Isn't that the next thing to do? There's nothing left.
Yeah. We transfuse
You do.
in that case, yes.
A great example, this goes back 10 years, maybe even more, where cited thoracic surgeons with the database was looking at stroke, and the only significant risk factor was that nadir hematocrit on bypass. But to your point in an earlier discussion was, okay, great, we've identified that, but what we haven't shown is if you then bump it up, that they're going to do better.
That's
and
the
quite
catch.
frankly, that whole conversation stopped, and we've never ironed that out. But I think that there are many of these phenomenon, and the hope is with big data sets, we don't have big data, little insight. We truly start to collect this information and see patterns that historically we were never able to see. Because one of the things I think I've learned, along with non-inferiority, are these studies that come out and say this one thing markedly changed everything else. I would say that's true if you were doing something very poorly and you intervened, but in the idea of a very good organization changing one drug or one intervention, markedly revolutionizing their result is almost
that's the secret of
unheard of.
ERAS, aggregation of marginal gains.
Correct.
We give you 25 things to do. Just do a few of them. You're going to see a huge benefit.
With AI, is I think we're really going to
tease
figure
it
out
out.
how much for which patients in which centers.
So I do think that blood transfusions are sometimes necessary, but I think we don't know the lowest, safest hemoglobin, and we operate way above whatever that value is. And I don't think we know how to discern which patients are going. Like, for instance, people tell me, my patient's on Levophed and they're anemic, and if I give them a unit of blood, they're going to come off the Levophed. And that is sometimes true, but it's not always true. And if you give a vasodilated patient a unit of blood, they're still on Levophed when you're done. We don't know the perfect way. I mean, we borrowed from the Virginia Quality Group. What we do if we have a patient whose hemoglobin is 6.2, and we don't just transfuse them because their mixed venous saturation is low. If it's 44 and their cardiac index is 2.5, we don't transfuse them, but we do check a lactate, and we use that as a sign. If the lactate's rising, we use that as a sign that even though the cardiac index is okay, they still need more oxygen carrying capacity.
My
And
problem
then
with
we'll
lactate
transfuse.
is so lagging. I mean, it tells you exactly what was going
It's
on
lagging.
eight hours ago.
I don't know if it's that lagging though. It's lagging, but
And, well,
it's
how
not
about
perfect.
the fact that it's got so many other things that elevate it, i.e. epinephrine. If you're on epinephrine,
Correct.
your lactate's up. So I'm
correct.
always
It's not perfect.
it's trendable, but in one number just doesn't do it for me.
Let's just say
I
that
agree.
it's a complex subject, but here would be an example. Say it's somebody like me that's relatively healthy, lower BMI, smaller patient, comes into the hospital with a hemoglobin of 8, has uncomplicated procedure, but their hemoglobin is 5 post-operatively. I think that that's different than, again, just 7 is our number or 6 is our number. And I think that we have to be very thoughtful about the context of the patient's pre-existing state, the rate at which these things happen, how likely are they going to be to recover.
Obviously, if you're bleeding too, I mean,
Correct.
all bets are off
All
with
of
that.
And we have robust data on Jehovah's Witnesses who do go home with hemoglobins of 5, and their outcomes are as good or better than
So
general.
my team asks me all the time, why don't we treat every patient like a Jehovah's? What's your answer to that one?
We should.
I think we should.
So why don't we? That doesn't. We all say we
Small
should, and we
blood
don't.
tubes, fewer blood draws,
So why
because
don't we do
that's
it?
one thing we don't talk enough about.
Why don't we do it?
Because it's change.
Change, money, time. It's just
Let
more work.
me touch on that because it was important when I was in Detroit doing congenital heart surgery. I was the person to do the kids that were Jehovah's Witnesses. But an extension of that, so I had a patient when I was at the University of Minnesota. He was a younger man with kids, and it was horrible to watch, but he got down to a hemoglobin of 0.7.
Oh, my
Oh,
God. Yeah, I can't. I mean, we don't want to look at that. That's the extreme.
But, it guides my
How did
thinking.
how
He
did
was
you-
alive for days as it continued to go down from 4 to 3 to 2 to 1. And the point is, just because we're at 7 doesn't mean we're going to die the next day.
Let's go back to the operating room. So we do know from trials that there's no anemic level on pump, which was associated with a benefit with giving blood. We do know that we can't figure out that bottom number. That kind of fits in what you're saying.
Published that.
That's right.
Correct. And in fact, getting back to what you were talking about earlier, if you were kind of alluding to oxygen delivery and goal-directed perfusion, and if Marco Ranucci has done a lot of the work on this, but he has a great graph in one of his earlier publications where he shows patients who had a low oxygen delivery, below 280 on pump, and he breaks it down whether it was low because they had low pump flow, like low cardiac index, or they were just anemic with adequate flow. And in fact, the risk of AKI was much higher if you had a low oxygen delivery because of a low flow rather than just being anemic with adequate flow.
Tried to tease out the.
And that's why I think mixed venous saturations aren't the best endpoint, because I think there's a difference in oxygen delivery deficit from anemia only with good cardiac output versus low cardiac output.
Well, I think that there's other factors too, like the pre-existing state of the patient, whether it's CKD or otherwise, but even these concepts of dose response, like how much for how long, because you could argue you could have a significant dip for a very short period of time.
On pump, low
is
low,
different than
low
a
too, yeah.
a moderate dip for a long
That's what's
period
been
of
shown.
time.
See, it's not the number, but the duration at which you're below
This
that
is
number.
that broken stick theory of how these
Trent
things
Magruder
work.
published on that and tried to use the area under the curve
That's
to
right.
get right at that exact.
Donnie Lakoski.
So last
in
topic.
Michigan.
So, and I hate to discuss this because it never happens, but let's assume you happen to be a surgeon that wasn't quite fastidious in checking the sternal areas and the mammary bed prior to closure, which may give you a little extra bleeding post-op. I know that never happens, but is there anything we can do with that other than slow
in the
down?
South,
You
we
read
call
about
that
it.
you can't fix stupid, right? You just got to do better.
Yeah, the anesthesiologists say, it's a proline deficiency. It's not a factor deficiency. That's what they say. But so do you use, Sridhar, checklists or anything to slow you down after a long case to make sure you've checked everywhere for potential bleeding?
Yes, it's in our protocol, so we follow all those protocols, even in closing the chest. So
Every time,
every
the same
time.
way.
Yes.
We have a bleeding checklist that most people follow.
Talk more about that, because you recently published on something, and I think this is maybe one of the most important things that we've seen in 10 years.
The bleeding checklist that we use is very simple, and it takes 2 minutes. It can be used after any operation, but if you say it's a cabbage, we check the neck area, which includes like the thymic fat and stuff. So we do the neck, we just move down. We do the cannulation site, any cannulation site. Then we do an area down by the diaphragm that we call the Landsman's area after Steve Landsman, because Dr. Landsman told me if that area is dry, you can close. Then we check an area we call the pit of despair, which is behind the heart, the left atrial appendage, but we don't lift the heart. We just hold the lungs and open that area up and look. And that area is great. It tells you if you've done like a mitral or a left atrial appendage procedure. It tells you if you have bleeding back there, if you've done an OM graft, and if you've done a Lehman LAD, you'll see the bleeding coming down into that area off the heart. So it tells you a lot. So we don't even lift the heart to look at the distals.
I love what you're describing is, in both cases, very systematic. One of the variations on this that I used, never use Ratex because they get lost and they're hard to count and so forth. But one lap on the heart, one above it. And what it allowed me to do, one, you come off bypass, you take some time, you think everybody feels a little bit better. Now you're not feeling like you're rushing. But now you know, is the blood coming from below or from above? Yes. And it's another good way to sort of segment your thinking.
The last part of our checklist is just the mammary bed if you took a mammary.
I mean, I do think that if you could lower the pesky ooze, as I call it, after cardiac surgery, that trickle of 100, 150 here and there, it just...
We do find like little things bleeding that we probably wouldn't have found. And then as we look at the mammary bed, and then we just take a look along the mammary itself, and we'll see sometimes like a little vein bleeding somewhere that probably would have given us some high output for a few hours and then not necessarily been a take back.
Another thing that we were talking about, Tom Schwann, Tom and I described this concept of dry in, dry out, wet in, wet squared out. And so you would have a lot of people that would just fly through that initial part of the procedure and never correlate the bleeding with what happens at the end. But if you're meticulous going in, I can tell you, you're going to be meticulously dry going out. If you go in and you're kind of slashing through things and working fast, you're going to either spend a lot of time drying up or you're going to take a lot of people back.
A personal impression of dealing with patients after COVID era, I believe something has changed in the thrombosis or bleeding sequence, I say. So I also checked the history of the patient. Did they have any COVID positive period for some time? Because it really can affect the outcome in bleeding. Sometimes they bleed, we don't expect them to bleed, or thrombosis, we don't expect them to thrombose. And also the patient that were introduced heparin very early, let's say they had an angiography at the age of 35, for example. So I believe there may be something like the heparin-induced thrombocytopenia or something starts very early when they face the heparin very early ages of their time. So these two groups, I'm always very much meticulous in controlling bleeding.
For people who want to decrease the amount of blood they're giving in their program, the number one effect that we've seen is from our what we call our ultra permissive anemia approach post-operatively. Tolerating anemia post-op will cut your transfusions more than anything else.
Tolerate down to?
We tolerate down to 6, but you can pick any number if you're compliant with it. You'll decrease your blood transfusions.
Which is probably better for your patients, is at least the theory that we're going to.
Definitely better
Yeah.
for your patients.
Yes.
I think that's great advice.
Great. Well, I'd like to thank all of our guests today, Dr. Gunyaden, Dr. Salinger, Dr. Lobdell. I'm Dan Engelman, and this is today's episode of the Cardiac Recovery Room. Thank you.